So next talk will be by Dr. Kiran Chandran. He is a consultant in Girdhara Institute. His talk is on OCT based differentiation of CSR and its atypical variants.
Good morning. I thank KSOS and Anubhav for giving me the opportunity to present today. My topic is OCD-based differentiation of CSCR and its atypical variants. So CSCR is characterized by the presence of serous macular detachments, and in clinical practice, CSCR has got a wide range of clinical presentation. So multimodal imaging utilizing a wide variety of imaging modalities helps differentiate acute from chronic CSCR as well as CSCR from CSCR-like variants. The commonly used multimodal imaging techniques in routine clinical practice is spectral domain optical coherence tomography, fundus autofluorescence, fundus fluorescent angiography, and indocyanine green angiography. They play important role in both diagnosis as well as classification and prognosticating the disease. Out of these, OCT is probably the single most important tool to diagnose as well as follow up cases of CSCR. So the various features seen in SD-OCD depends on the stage of the disease, and they include serous retinal macular detachment, especially in the acute phases. Then hyperreflective foci within the serous macular detachment. These are indicators of chronicity and indicates the longer duration of fluid in these patients. Outer retinal abnormalities again are signs of chronicity and include ellipsoid zone, ELM deficits, as well as staining and irregularity of the retinal pigment epithelium. Retinal pigment epithelial detachment, the most common type of PED seen are the serous PED, and they are known to be present in around 50 to 100% of eyes of CSCR, especially in the acute stages. And sometimes a small discontinuity in the RP over the PED could be seen, and this is described as the RP rip. So over here we can see the fundus photo of a patient in acute CSCR. The orange arrowheads depict an area of serous macular detachment. And on fundus angiography, fluorescent angiography, you can see an ink spot pattern of leak just superior to the fovea. Fundus autofluorescence also shows areas of hyper autofluorescence surrounded by hypo autofluorescence corresponding to the leak. And on spectral domain OCT, you can see a uniform hyperreflective space in the neurosensory retina between the RP as well as the photoreceptor layer, so indicating of subretinal fluid in the macula. And the choroid is also an important area to analyze in these patients because all these patients are pachychoroid. This is a patient of chronic CSCR in which an area of serous macular detachment can be seen, a large area. And within it, you can see numerous discrete yellowish white lesions clustered around within it. And fundus autofluorescence shows an area of mottled hyperautofluorescence. And fundus fluorescent angiography shows an area of ink-blot pattern of leak. And the interesting finding in OCT in these chronic CSCR patients is that there's elongation of the photoreceptor inner segment, outer segment layers indicated by this green arrowhead. And the yellow arrowheads depict an area of hyperreflected dots seen within the photoreceptor plates. And these basically indicate the deficient RP phagocytosis function in CSCR patients. This is a chronic recurrent CSCR in which you can see an RP gravitational tract beautifully seen on fundus autofluorescence, in which there's a mottled mixed pattern of autofluorescence. And again, fundus fluorescent angiography shows a mottled pattern of hyperfluorescence because of window defects or RP defects. Indocyanine green angiography shows direct choroidal vessels along the tract as well as an area of hyperfluorescence in the macula. And on OCT in these patients, there will be more RP thinning, irregularity of the retinal pigment epithelium, small elevation of the RP above the Brooks membrane, hyperreflected dots in the choroid, as well as collapse of the inner into the outer retinal layers. So this is a patient in which the right eye shows a yellowish white lesion just superior to fovea subretinally. And on OCT, you can see an RP rip that is disconnecting the retinal pigment epithelium. And just above it, you can see subretinal hyperreflective material. And between this subretinal hyperreflectivity and the RP rip, you can see a vacuole. It's called a vacuole sign in CSCR. So choroid, as I told you, is important to analyze, especially the enhanced depth imaging. So based on various studies, 395 micron is used as a value to diagnose pachychoroid. So subretinal hyperreflective material in CSCR was first reported by GAS, and this condition is more prevalent in pregnant women and those with steroid intake. Although CSCR classically presents a clear SRF on OCT, subretinal deposits may be seen that appear hyperreflective in OCT, described as SHREM or subretinal hyperreflective material. So the OCT features in fibrant CSCR clearly shows a dipping or sagging sign, that is a tent-like depression in the neurosensory retina between the retinal pigment epithelium and the fibrant material, and they basically act like a cushioning effect, like adhesive between this PED and the neurosensory retinum. So the presence of vacuole sign, as I told you, indicates sites of constant fluid egress, and on FFA they correspond to areas of RP leak. So this is another example of a patient with fibrant CSCR in which subretinal hypertrophic material can be seen over here. This patient does not have a vacuole sign, but subretinal fluid can be seen, RP discontinuity, and hypertrophic dots overlying the photoreceptor layers. So other simulating conditions of CSCR, the most important thing is to rule out leakage because the treatment varies in both. Subretinal fluid is present in both conditions. In leakage, you see folds of RP, fluctuation in the ILM and subretinal septa. As you can see in this diagram, RP undulations are seen, multiple pockets of subretinal fluid, ILM folds or fluctuations are seen. Subretinal septa actually separates multiple pockets of subretinal fluid. And another interesting finding is called the Ballard or basilar layer detachment, in which a myoid zone is split and it gives an appearance of interretinal fluid accumulation. And the differentiating feature of subretinal fluid over here compared to CSCR fluid is that it's more homogeneous in CSCR, which appears hyperreflective, whereas this appears like mild hyperreflectivity can be seen within the hyperreflective area because of fibrin and other material deposition within it. So this is another case which is saw in OPD, in which RP mottling can be seen in both the right and left eye diffusely, and fundus autofluorescence picks up this mottled area of mixed autofluorescence. And on OCT you can see multiple the interretinal cavitations more look like skytic cavitations in both the layers, both the eyes, and shallow subretinal fluid can be seen, RP elevation and hyperreflective and significant thinning of the RP can be seen. There is a patient with uveal effusion syndrome in which peripheral examination is very important because this is a diagnosis of exclusion, and the treatment also varies. OCD shows multiple large areas of subretinal fluid accumulation as well as RP irregularities or elevations. B scan is diagnostic as well, which shows choroidal effusions, choroidal detachments in B scan. This is a patient in which exudative retinal detachment in a patient with CSCR, in which subretinal fluid can be seen, and inferior retinal detachment is also seen on OCD sections. And on fundus fluorescent angiography, a leak can be seen in the upper nasal quadrant. This patient is actually lasered and improved vision-wise as well. So the other important masculine is polypoidal choroidal vasculopathy because both fall in pachychoroid spectrum. ICG is, and OCD should be done in tandem to differentiate these two entities because ICG identifies PCV as areas of polypoidal lesions and branch vascular complexes. So this is a patient of acute CSCR in which an area of, you can see area of serous macular detachment and yellowish orange lesion can be seen at the fovea, and drusenite deposits can be seen scattered around the macula. Fundus fluorescent angiography shows a leak, in-glot pattern of leak in the late phases, and on ICG you can see hyperfluorescence in the mid phase or phase of polyps. And OCD sections taken through the polyp shows notched PED, and sections through the leak shows subretinal fluid and serous PED. So this patient had coexistent PCV as well as CSCR. This is a patient of chronic CSCR in which you can see RP gravitational tract, and on ICG, when we did ICG through the polyp, you can see a thumb-shaped polypoidal lesion, thumb-shaped PED as well as subretinal fluid. A double layer sign can be seen, separation of RP from the underlying Brooks membrane, and minor patchy areas of interretinal fluid. So this patient again had coexistent PCV with CSCR. Type 1 macular neovascularization is CSCR because it can mimic KSCR, type 1 macular neovascularization. So in these patients, double layer sign is present, as I already explained. It's a separation of RP from the Brooks membrane. So I can see just you cannot see much fluid on clinically. You can see RP defects as well as prominent orange discoloration of the fundus. Very faint suspicious leads can be seen on fundus fluorescent angiography, and dilated choroidal vessels can be seen on ICGA. When we did an OCT, we saw a subretinal fluid at the macula and a subtle double layer sign, that is RP is getting separated from underlying Bruch's membrane. And on Octa, we found a network in a C-fan pattern at the RP Bruch's complex area, suggesting of type 1 neovascularization. So the last masquerade is best vitiliform macular dystrophy. So it presents as a bilateral yolk-shaped lesion affecting the macula. The classic pseudohypopia may not be visible in all cases, and ancillary testing may be needed. So this patient had a vital eruptive stage of Best disease, and a subretinal yellowish-white lesion can be seen in the macula with discrete yellowish lesions scattered around the boundaries. Fundus autofluorescence shows those hyperautofluorescent dot-like lesions, along the boundaries of lesions with mixed autofluorescence centrally. And on OCT, you can see discontinuity in the photoreceptor layers between it. The ELM is continuous, and you can see the yellow arrows, the blue arrows depicts the external limiting membrane. The red arrow over here suggests areas of narrowed outer nuclear layer, and the photoreceptor layers have lost continuity. They appear disruptive. And this mound that you see over here is corresponding to the yellowish white lesion seen subretinally. So these are few of the masquerades and distinguishing features of CSCR on OCT. Thank you.